pediatric and functional sections, where today's experts will discuss neurosurgical treatment options for spasticity in cerebral palsy. I want to make one quick note before we get started. I want to encourage you all to actively participate by writing down your comments and questions in the Q&A box, and we will have a discussion between the second and third lecture, as well as after the fourth lecture. So you can pose your questions at any time, and I will check this regularly. We also have with us Professor Radek Frick, who is the section chair of the pediatric section.
Well, good evening, everybody. I will also welcome you in this webinar. It's the first joint webinar with the functional section. I'm very happy for that because we have many topics in common. So for today, the topic is the treatment of spasticity. And let me just introduce the first speaker, Professor Sergei Gorishev from Moscow, who will give the first lecture. Sergei, please.
Yeah, thank you. Okay, do you see my slides? Okay, yeah.
Yes.
Okay. So, dear colleagues, the treatment of cerebral palsy is a multidisciplinary topic. There are many controversies and unclear indications for the surgical treatment. Moreover, these patients remain disabled for the whole life. That's why the problem of transition from pediatric to adult healthcare systems, as well as their further treatment in adulthood, is also an important one. So my report will be focused not only to the methods of treatment, but to the general introduction to the problem. So, and one of the main features of the treatment of these patients is a teamwork. So the general scheme of the CP management is shown on this slide. It includes the oral drug treatment, physiotherapy, botulinum toxin therapy. If it has positive effect, then rehabilitation. If no effect, there may be used the neurosurgical treatment. And if it is effective, in the absence of contractures, rehabilitation. If still we have fixed contractures, then orthopedic surgery and again rehabilitation. So the CP team includes at least a neurologist, rehabilitologist, orthopedic surgeon, neurosurgeon, speech pathologist, and physiotherapist. The role of neurologist is in making a diagnosis of cerebral palsy, clinical assessment, conservative treatment, botulinum toxin therapy, determining indications for examination by neurosurgeon or orthopedic surgeon, and clinical assessment of patient after surgical treatment. The role of neurosurgeon is to check the indications for surgery, choose a method of treatment, perform surgery, and to send the patient to a rehabilitologist. But on this way, there are a lot of barriers. So these barriers include patient and family, healthcare professionals, and healthcare system. From the side of a patient, this is a dependent behavior, immaturity, severe illness or disability, psychopathology, lack of support systems, poor adherence to treatment regimens. On the side of family, this may be excessive need for control, emotional dependency, parenting styles leading to overprotection, heightened perception of disease severity, lack of trust in caregivers, or mistaken perception of potential survival. Barriers in training and availability of key specialists. Not all pediatric neurosurgeons are involved in the treatment of spasticity, which needs additional training. Those who are involved are not ready for close cooperation with the team of other specialists. Many neurosurgeons specializing in the treatment of adults profess an inability to manage spasticity in children. Neurosurgeons not used to following CP patients may not appreciate the need for long-term follow-up of these patients. Neurologists have the potential to play an important role in the care of children and adults with cerebral palsy. However, they receive formal education in the pathophysiology, diagnosis, neurology, and treatment of spasticity, but have minor information about surgical methods of treatment. Rehabilitologists have a great role in the care of patients who require longitudinal drug management for mobility, spasticity, and orthosis, but they may not have additional training to treat children after surgical treatment of spasticity. In areas with limited access to the neurosurgical care, primary caregivers provide the initial response to patients' concerns about their illness, but primary care professionals are often uncomfortable caring for patients with complex conditions, including cerebral palsy. Healthcare system barriers. So there may be several models for the treatment of such patients. One is for patients to remain with their pediatric neurosurgeon, neurologist, and rehabilitologist after they become adults. But the model works only where pediatric specialists have privileges in adult or general hospitals, or where pediatric hospitals allow the admission of adult patients. So it's not a solution for the long-time care on a large scale. The second model may be for patients who have gone through healthcare transition to be seen in programs that specifically provide long care for adults with cerebral palsy. So these need special medical centers for the treatment of patients with cerebral palsy. Thus, now we have the limited availability of such programs and centers. Not uncommonly, fee structures don't adequately reimburse the practitioner for the time that is spent managing complex patients with cerebral palsy. And at last, this is the problem of health insurance. In some countries, persons with pre-existing conditions allows young adults to stay on a parent's employer-based insurance plan until the age of 26 years. But children who have other children's healthcare insurances may lose coverage at the age of 19 years. I can show you one of the models of the healthcare for children in Russia on the example of the one medical center in Yekaterinburg. So this is the center for children with healthcare disorders. So they provide in one center surgery, functional impairment compensation, family and child social adaptation, and communication skills development. Thus, they provide special educational courses, surgical treatment, botulinum toxin therapy, orthopedic support, high-tech diagnostic and treatment equipment, robotic systems, spa therapy, as well as social and psychological support. In such center, a patient is provided with the different methods of combined treatment, including rhizotomy, baclofen pumps, orthosis, botulinum therapy, physical therapy, specialized suits, so they were designed for the spacecraft, kinesiotherapy, mechanotherapy, as well as courses for parents with social worker support, psychological and speech therapy correction, and drug and even reflexotherapy. So this is the multidisciplinary rehabilitation team, which includes physiotherapy specialists, rehabilitologists, nurses and clinical staff, speech therapists, psychologists, occupational therapists. It's very important that the results of treatment and effectiveness of treatment is estimated on the variety of scales, by the variety of methods, including the Ashworth scale, the GMFM scale, the GMF-CS scale, stabilometry, balance scale, electromyography, Edinburgh Visual Gait Score, cost index, and other tests which are being performed in every patient, so which is being treated in such a center. In our country, we have the special program for the treatment of these patients, and it may be divided into several stages. So the outpatient and clinical care for children in perinatal risk groups for cerebral palsy, and dynamic observation for the group of children with confirmed cerebral palsy diagnosis. On the first level, in the postoperative period in a surgical hospital. On the second level, in the chronic period, in specialized rehabilitation centers or departments. And on the third level, in the follow-up period, in outpatient departments and spa centers. So, to conclude, the strategy for the complex medical care for children with serious healthcare disorders is maybe the following, so we may discuss it. So the goal is the maximum physical and mental health recovery of a child and his family, adaptation for school learning and normal communication with peers, multimodality treatment at the same time in the same place, and disability prevention, which includes early diagnosis, surgery, and treatment. So, dear colleagues, this, I think, may be the introduction for the following discussion. So I tried to show you this problem, to show the complexity of the treatment of these patients. And now we can proceed to discuss the role of a neurosurgeon more thoroughly. Thank you.
Thank you, Sergey. The next speaker is Dr. Simone Wolter from the Charité Institute in Berlin, who is an expert in neuromonitoring, and she will discuss the role of electrophysiology in SDR, selective dorsal rhizotomy. Please, Simone.
Okay, let's see. Can you see my slides?
Not yet.
Not yet.
No.
Okay. Okay.
Yes,
Fine.
I've made the presenter mode. Yes, here.
Okay, I have to go back.
Excellent.
Okay, and now thank you for the time I got. So, good afternoon, ladies and gentlemen. Today I'd like to talk about the role of electrophysiological neuromonitoring in SDR. And I will talk about it in connection with our SDR study results to make clear what you can get from the neuromonitoring part. The focus, of course, will be on children with cerebral palsy undergoing selective dorsal rhizotomies, or SDR for short. In the video on the top of the screen, you can see something about this minimal invasive intervention. However, more specifically, we're talking about the role of electrophysiological monitoring. More specifically, we will be looking at the 50 Hertz EMG responses evoked by threshold stimulation. And for our study, no specific grants, and so I have nothing to declare. Let's start off with an overview of the steps we will follow. Our goal: how does interpretation of the EMG features helping us to achieve our goal, which is to assist in decision-making while operating? And what additional information can we obtain from these EMG responses during rhizotomies? For example, information on cardinal signs of cerebral palsy, such as hyperreflexia or co-activism of antagonist muscles. So, and our methods, 2 different types of stimulation were administered: autodrome during the rhizotomies Only the high frequency responses were graded according to a response classification system and then analyzed. Our results: stimulation evoked EMG response patterns revealed significant differences along the segmental levels and varied according to the site and gender. So our conclusions: comprehensive neuromonitoring of the rootlets should be carefully conducted during SDR. And we heard before, it is an interdisciplinary team for SDR and for children with cerebral palsy. So bearing in mind the potential usefulness of the results obtained for those designing subsequent rehabilitation programs. So let's a few words now about cerebral palsy, or CP for short, which is the most common severe and costly motor disability in children. Spinal reflexes reorganize, producing hyperreflexia, muscle overactivity, and spasticity. So the etiology has proven complex, making it difficult to move forward in preventing it. So getting back to our main subject, which is the role of electrophysiological neuromonitoring in SDR and the information we obtain in this process. In recording EMG responses, two different types of stimulation were administered to the sensory nerve root or to the rootlets. However, only the high frequency stimulation responses elicited assist us in surgical decision-making and in pinpointing those rootlets which contribute most to the muscle overactivity on the segmental levels and to spasticity in general. In grading our 50 Hertz responses elicited, we saw in the video before, we use, among other things, this response classification system devised by Phillips and Park. The grades, the higher the grades, the more intense or extensive the responses are. For example, look here at grade 4. The response is, and we only stimulate the rootlets on the left. This is the right-hand side. The response is highly abnormal with regard to the contralateral spread. At grade 3, we stimulate L5 left, is abnormal in view of discharges at multiple levels. Grade 0 on the top of the screen, however, signifies the absence of abnormalities and responsiveness to high frequency stimulation. And let's bear in mind that 30 to 50% of the rootlets per nerve root are to remain intact, preference being given to the lower graded ones. This was the method. Now I would like to turn to our retrospective study, which was approved by the local ethics commission. We conducted this investigation on SDR neuromonitoring, analyzing EMG responses in 146 patients, applying this a response classification system from grade 0 to grade 4, which you have seen before, and investigating the distribution of the grades and the prevalence of the grades. assessed in more than 7,000 rootlets. And this was our statistical evaluations. I will not go to every detail, but making use our statistical evaluations, we found significant differences along the segmental levels. And this typical rostrocaudal anatomical distribution. This was for grade 0. And comparison of grade 3 and 4 prevalence showed that there were more higher graded rootlets on L5 and especially on S1. And please note also the lateral distribution. We have found many more grade 3 and 4 rootlets on the left, and they are more often observed in the boys than in the girls. In these pie charts, you can see again the differences between the girls and the boys along the segmental level. A close link to higher graded assessments, what is grade 3 and 4, all this marked in red. And you can see here a left bias asymmetry. This has become apparent especially in boys and in patients with GMFCS level 1, which is shown here. Right-hand side, left-hand side, and much more grades 3 and 4 in these patients. A long time before we started our SDR study with EMG responses, others had also described gender-specific differences in connection with cerebral palsy and asymmetries. But we did not look to EMG responses. Graces has pointed out 3 related mechanisms which set in following an upper motor neuron lesion, none of which are symmetrically distributed. And Martin and his team observed the following: when only one hemisphere of the brain suffers injury, asymmetries emerge in response. And so it is no surprise that we have found differences between the right and the left and between the levels and in girls and in boys. So conclusions. The etiology of CP is highly complex, and so far there is no possibility and no success in preventing it. Thus, methods such as the minimal invasive SDR will continue to be of use. SDR involves sectioning sets of rootlets which on threshold stimulation show exacerbated muscle responses due to impairment. The information on the recorded EMG response patterns is crucial for 2 reasons. Firstly, it affects the surgical decision-making process in the OR. And secondly, it sheds light on the spinal functional state at the time at SDR. This might prove very important when it comes to developing programs for rehabilitation programs, including muscle training and rest periods. So, and now I hope that you will agree that special EMG patterns and muscle activations evoked by rootlet stimulation should be carefully noted during SDR. special thanks to all who helped in carrying out our study, to our interdisciplinary team, what is very important to be interdisciplinary, and to our SDR patients. And thank you all for your time and attention.
Okay, thank you, Simona.
Okay.
I don't see any open questions. Again, you can put your question in the Q&A box if you want, but then I see questions coming right now. I'm sorry.
Yeah.
There are some. Which EMG responses interpretation you use in your routine practice? Park, Broad, you know.
Our interpretation is very close to the response classification system from Park and from Philips, but we also use the Peacock differentiation, because if you have rootlets only with the same grade, and you have to separate between, then we use also this pattern to say, oh, this is very abnormal and very intensive, and we also differentiate the rootlets by the health of by means of this Peacock classification.
Second question is how to distinguish ventral from dorsal roots using electrical stimulation.
Yeah, sometimes it is not so easy in these patients, because normally you can use the threshold. The motor nerve roots have a very low threshold, but in these children you have usually a very low threshold, and so it is sometimes not so easy. We help us a little bit in with tapping. It's a mechanical intervention to see if there is a response, and then it is a motor nerve root.
And the next question is about how many muscles are tested for each rootlet in general.
We have these 8 muscle groups on both sides. We observe all the time during the rhizotomy.
Okay. And then one question which I also had more or less is, if one of the rootlets have abnormal response, do you cut totally or partially? And how many rootlets do you end up when you do the, sectioning?
It's
on average, of course.
It depends on the grading, but the rule is 30 to 50% per nerve root are to remain intact, and the preference being given to the lower graded ones. Grade 0 is the best. Grade 1, if all the others are grade 3 and 4, when you leave these intact and cut the higher graded assessments.
Yeah, but even if you cut 30%, you can divide one root into 50 rootlets and then just cut, let's say 15. Or you can just take 5 and cut 2 of them. That's more or less what I meant. How many divisions do you have on average? Of course, it depends on each nerve root, of course.
What I have seen is approximately, I'm not the surgeon, so, but what is usually most of the time I see 4 rootlets, but it is also depend on the nerve root. If you have a really big size, then you have more rootlets as 4. Okay. And decide what rootlet or rootlets with higher grading should be cut.
Two more questions. Will the study
Yes.
of EMG response in SDR be effective in young adults with CP? Please make a speculation on this. Thank you.
We had only children, so it's I don't know.
What is the upper age limit in your experience, more or less?
And
Or
in the middle, the patients are 8 years or less, much less. And we had also one patient with 20 years, but not higher. Dr. Park is doing adults also in St. Louis. I know this because we learned this monitoring from him and his team.
And then the last question from a colleague from Slovenia. What if you get only grade 0 responses? Probably not desirable.
If this is the case, the surgeon decide what rootlet what sectioned.
Okay.
When it is not my part. I cannot. I can only say what I see.
And probably check with the anesthesiologist maybe also.
Oh yeah, you have to talk to the anesthesiologist because the procedure of the anesthesiologist should be adapted to the neuromonitoring. But this is in all the operations where we use neuromonitoring.
Thank you so much, Simon.
Okay, welcome.
Mm-hmm. Okay, so we may proceed. Yeah, Tom. Okay, excellent. So the next speaker, we shall have Philippe.
No. Normally it would be Dr. Andrei Dekorov.
Andrei. Okay.
And I see that Dr. John Gooden also arrived. So welcome.
Yes. Yeah, I'm happy.
Then we will have a short break and then Philippe will go. Thank you.
Okay, so I will introduce Andrei. Andrei Dekopov is a neurosurgeon from the Burdenko Neurosurgical Center. He's involved full-time to the functional neurosurgery, both in children and adults, and has a huge experience in this field. He's in the specialized group of neurosurgeons which perform the functional neurosurgery, and I hope that he will share his experience. Andrei, please.
Good evening, ladies and gentlemen. You can see now my presentation.
Yes. Yes.
Okay. Our report is dedicated to neurosurgical treatment of CP spasticity. There are several methods of treatment of CP spasticity, like physiotherapy, oral drug treatment, botulinum toxin therapy, and neurosurgical treatment. The indications for neurosurgical treatment in CP spasticity are inefficiency of oral drug treatment, inefficiency of botulotoxin injections at least 3 times, high level of spasticity, threat of occurrence fixed contractures, and optimal age for surgery is from 3 till 7 years old. There are 2 groups of neurosurgical interventions in treatment of spasticity: destructive surgery, including selective dorsal rhizotomy and selective peripheral neurotomy, and surgical neuromodulation, chronic intrathecal baclofen therapy. The indications for selective peripheral neurotomy is a focal spasticity resistance to botulinum toxin therapy. Depending on level of spasticity, neurotomy performed on different peripheral nerves. For spastic foot, the target is nervus tibialis. For spastic adductor, nervus obturatorius. For spastic elbow, musculocutaneus, and for spastic wrist, nervus medianus. At first, we perform preparation of motor branches of peripheral nerves, then divide it into several fascicles, and perform intraoperative AMG. Then we cut fascicles which give high amplitude muscle contractions, and to achieve clinical effect, usually it's enough to cut about 50% of motor fascicles. This picture shows results of selective peripheral neurotomy. You can see regress of foot deformities after neurotomy of nervus tibialis. The dynamic of muscle tone after neurotomy in follow-up shows that in most cases we revealed significant decrease of muscle tone, and just in 10% of cases we have observed recurrence of spasticity. Selective dorsal rhizotomy indications. Patient with severe spastic low paraparesis or tetraparesis, high level of muscle tone, 3 points and more, inefficiency of oral drug treatment and botulinum toxin therapy, absence of muscle dystonia. This picture shows a position of patient for SDR, X-ray mapping, and placement the electrodes for AMG, intraoperational AMG. The AMG electrodes was installed in following muscle groups: hip adductors, musculus vastus lateralis, biceps femori, semitendinosus, gastrocnemius, and also in the perianal sphincter to prevent the bladder dysfunctions after the operation. The approach performed via L1 laminotomy, then dura mater is opened, and we preparate the posterolateral groove and dorsal roots from L1 till S1. Each root is divided into 4 or 5 rootlets, and then we perform intraoperational AMG. Pathological rootlet sync was high amplitude, spreading on several muscle groups or spreading to the contralateral side. The volume of root resection was from 50% till 75%, depending on results of AMG, intraoperational AMG. But for each roots, no less than 50% and no more than 75% of volume. This picture demonstrates the results of SDR, regress pathological crossing of legs, and regress deformity of the foot. The dynamic of muscle tone in follow-up after SDR. You can see that in most cases, we observed a significant decrease of muscle tone. during several years after the operation. And just in 15% of cases, we have revealed a insignificant increase of muscle tone in follow-up, but within from half till 1 point Ashworth scale, not more. And in intrathecal baclofen therapy, indications cerebrospastic low paraparesis, tetraparesis, and gemiparesis, high level of muscle tone, inefficiency of oral drug treatment at botulin toxin therapy, and positive results of baclofen trial. We have implanted a spinal catheter at T5, T6 level in patients with spastic low paraparesis, and in spastic with tetraparesis, catheter was been implanted in cervical level. Implantation of pump was performed under the muscle aponeurosis to prevent atrophic skin disorders. And the daily dose titration. Usually, initial dose was from 1 till 1.5 from bolus dose using during baclofen test. And then we increase the daily dose every day on 25% until the clinical effect is achieved. And then we perform the correction of daily dose during each refilling procedures. This picture demonstrates the dynamic of baclofen daily dose in follow-up. And in all cases, the daily dose tends to increase. The dynamic of muscle tone after pump implantation. During first year after the operation, we observe decrease of spasticity, but subsequently muscle tone tends to increase. Tends to increase despite enlargement the baclofen daily dose. In 10% of cases after pump implantation, we have revealed the secondary resistance to ITB. The clinical effect was regressed 6 months after the operation, from 6 to 9 months after the operation, and muscle tone increased till preoperative values. There are no any problem with pump or spinal catheter in all these cases, and increasing of daily dose or using some flexible regime baclofen intrathecal infusion had no clinical effect. And in these cases, the pump have been removed. This picture demonstrates compare of muscle tone dynamic after SDR and ITB. You can see that the results are comparable only during 1 year after the operation, but subsequently a significant difference appears in level of muscle tone after SDR and ITB. So conclusion, when we can conclude that the results of SDR and ITB are comparable just only during 1 year after the operation. Decreasing of muscle tone after SDR is in the follow-up 1 year and more after the operation, more significant than after ITB. The clinical effect of ITB may reduce and follow up. We have shown that we find in 10% of patients secondary resistance to ITB. And so if absence of muscle dystonia, SDR is more preferable procedure, both in children prospect for motor rehabilitation and in children without prospect for motor rehabilitation to decrease spasticity. Thank you for your attention.
Thank you, Andrei. So, thank you for your report. You really have a great experience, which made possible to compare different methods of treatment in one hand. So there are several questions to you and other speakers. So I think that we shall discuss it after the next speaker. So be ready to answer the questions and to discuss some topics. So, and now I'd like to welcome Professor John Gooden. He's a consultant neurosurgeon, both adult and pediatric, in the Leeds Children's Hospital. John, am I right?
Yes, you are indeed. Absolutely.
Yes, please, please.
Right thing for green share. Hopefully that's not working.
Yes, it works. Fine.
Thank you. There might be a little bit of repetition between this and the other talks, which I guess is not a surprise because we're all talking about a similar thing, and there should be some crossover between the treatments anyway. So I hope this gives you a helpful overview on selective dorsal rhizotomy. I practice a single level technique that I learned from Dr. Park in St. Louis, and learned that from him back in October 2010, and have been doing that for the last, did our first case in October 2012, so I've been doing it for the last 12 years, or just under. So, as you know, cerebral palsy is a permanent disorder. And that's the critical thing with considering selective dorsal rhizotomy. This is an irreversible brain injury that isn't going to suddenly change later on over time. And because I'm doing a treatment that is a static treatment, fixed in time, is not redone, is not altered, I need to do it in a static injury background picture. I can't adapt my treatment. And that's the clear difference between intrathecal baclofen and selective dorsal rhizotomy. If you've got a progressive neurological disorder, then ITB, a treatment which you can adjust with various drug concentrations and change the drug frequency, those sort of things, you can adapt that treatment to the changing child's condition. So that's the important thing about cerebral palsy and having that fixed injury. Selective dorsal rhizotomy has been around for a long time. It was first described in the cat model of cerebral palsy by Professor Charles Sherrington in 1898. First human patients reported by Uhtred Foster in 1913, but that was cutting all the sensory nerves and was also pre-antibiotic era. So if you cut all the sensory nerves, you end up with loss of proprioception. So where my colleagues have been describing cutting 75%, no more than 75%, that's because we're trying to avoid the loss of proprioception, which is critical if we're trying to help kids be able to stand and move and improve their function. Gross and Fasano helped move the work forward in the 60s and 70s, looking at partial section. And then, of course, Professor Peacock in 1981, publishing his series of rhizotomy patients with a multi-level laminoplasty or laminectomy. And then people such as Dr. Park and then others also investigating this, Dr. Park reducing that down to a single level approach, which is what I learned. And of course, the other thing with cerebral palsy is there are a group of different movement disorders. So as you can see on this diagram, you can have your spasticity, but you can have dystonia as well. Spasticity only is helped by SDR. we will not help dystonia or dyskinesia. And so we've got to be clear about the target for the treatment. We've got to be clear that that patient is really going to get benefit from our treatment, and make sure that we set those expectations right when we're thinking about the treatment. You'll hopefully be familiar with these Rosenberg curves describing the different functional levels at the different GMFCS levels. Most children eligible for SDR are going to be functioning in this GMFCS 2 to 3 bracket, but there are people doing SDR for GMFCS 4 and 5, and I'll talk about that in just a second. The issue with all children is they grow, and as they hit the teenage growth spurt, they get heavier, the central gravity changes, they're taller, and the extra body weight, the change in central gravity means that a number of children then lose function as they go into the teenage growth spurt years, and they end up in a wheelchair in their early teenage years because they're heavier, they're taller, they can't move so freely. And this is one of the particularly interesting things with SDR, is can we prevent that? Certainly for these GMFCS 2 and 3 children, can we prevent that? And how does it play out for the 4s and 5s as well? There's a lot of literature out there for SDR. There's been a lot of debate over the years. And that's partly been driven by the fact that when Warwick Peacock's paper was published in the early 80s, SDR was used on a number of different conditions. And so harm has been done surgically with us doing irreversible operations that has caused harm to patients. And so there's been a lot of investigation as to when do we need to use it, but there's also a number of people who are dead set against SDR because of these publications from the 80s and late 80s, early 90s, showing harm being done from the procedure. Long-term studies are showing that SDR can have good long-term outcomes. We're doing our 10-year follow-ups at the moment. We're following up patients with physio reviews, looking at GMFM, looking at Ashworth scores, looking at quality of life changes over a 10-year period following the SDR. It gets difficult beyond that because these young children become young adults. They get lives, they get busy, they get university, they go off to places, and they don't necessarily want to come along and be poked and prodded anymore to help us understand what's going on. If we think about the caseload, actually, when you start reducing the numbers, so if we look at the UK figures of 630,000 live births in 2021, 1 in 500 have cerebral palsy. 20 to 38%, according to the literature, will have diplegia. That's quite a wide range. 20 to 40% are reported in the literature for the rates of GMFCS 2 to 3 without dystonia. And then when you combine all of those, you end up with a figure of only about 8% of those children needing, having the combination of spastic diplegia and GMFCS 2 to 3, which in the UK population would be this sort of range of 110 or so new cases across the country. So not huge numbers of people in that classic category. We look at our patients through a fortnightly spasticity clinic, where at the moment our ITB service is not running because of various logistical problems, but where we're looking at them to consider the role of SDR. And we run it as an MDT service. We have input, if necessary, we can get input from orthopedics and plastics. And this is the thing, that SDR is one of the treatment options on a shelf with different options. And we're not trying to fit children into an SDR box. It's of these different range of treatments. We've just heard about ITB, heard about peripheral neurotomy. These are other treatments for spasticity, and which is the right thing for us to use for that child. And you need the multidisciplinary team approach to consider that. So for our SDRs, we might be on the conservative side, but we are looking for children who are functioning at GMFCS level 2 or 3. So they're generally ambulant, they're mobile, either with sticks or a K-walker frame. Some of them might have some degree of independent stepping. The MRI scan I'll show you a picture of in a second, but they've got to have the typical changes of white matter injury beside the ventricles, periventricular leukomalacia, or white matter injury of prematurity. And they've got to have no injury to thalamus, basal ganglia, brainstem, cerebellum. because those will be other factors controlling movement. The youngest I've operated on is 2.5. The oldest I've operated on is 19.5. So a range of ages available. We want to see that there is spasticity that is affecting their movement and that this is having an adverse effect on their ability to function. We want to see that there is no dystonia, and we want reassurance that they don't have a genetic or progressive neurological problem. And they've got to have enough strength. If you can't stand pre-SDR, you won't stand post-SDR. So if you can't stand, you can't rehab. So being able to stand and engage in rehabilitation is an absolutely critical thing. Scoliosis makes life harder, but isn't a hard no to SDR. Hip dislocation needs treatment ahead of SDR if it's present. So if a migration index is more than 50%, then that needs to be treated before they have SDR surgery. So this is an example of periventricular leukomalacia, this thin white band beside the ventricle. On the coronal scan, you can see it here. And that's indicating this is the part of white matter that has been injured around the time of birth, giving the cerebral palsy. We want to see that that's there to help confirm that diagnosis. There's softer things as well. We want to make sure that they're going to comply with follow-up. We want to make sure that they're going to come along and see us, and we want to make sure they're going to comply with the physiotherapy. If you don't have physio post-SDR, there's no point in doing the SDR surgery as far as I'm concerned, because the physio and the work that the family do with that physio is critically important to their overall outcome. If they've had Botox recently, we need to make sure that's worn off. And if they've had orthopedic surgery, they need to recover the strength. And that often does take a year. So just delay for that time. Grey areas, in particular, just draw your attention to the 4s and 5s. So children functioning at GMSCS level 4 and 5 are a harder group to work out. They often do have a lot more weakness. They've often got some upper limb involvement as well. They've often got some dystonia present as well. And we know that SDR is mainly affecting the legs, but those of us doing SDR regularly will have a cohort of patients who turn around and say, actually, upper limb function has improved. It's odd, it doesn't fit with neural pathways, but most of us have observed that, and there's certainly some case reports out there as well. With the GMSCS 5s, that's easier, because those children are wheelchair bound, and by doing SDR for those, you help with pain, you help with spasms, and you're not risking functional transfers. So doing it for those children is easier. There's less at risk if they lose function. Whereas a GMSCS 4 patient may be relying on some strength in their legs for standing transfers to get from their chair to their bed, to get from their chair to the toilet. And that might be at risk with SDR for the GMSCS level 4 children. It might not. I'm not saying it's not safe for the GMSCS 4s, but it's part of the consideration the MDT have to think about. So with our patients, most of the time I do an SDR on a Thursday, which works well for our pathway because I leave an epidural in for pain relief that stays until the Saturday, leave a urinary catheter in, and then usually on the Monday, they got out of bed for the first time and the bladder catheter is taken out and they're mobilized with physio from that Monday after their surgery. And we have a regime of 3 weeks, Monday to Friday, of, we call it outpatient-based therapy. The child is put up, stays locally, comes in daily for either 2 half-hour blocks or a 1 hour block of physiotherapy, intense therapy over that 3-week period. By the time they're leaving hospital, we generally say they're back to about 80% of their preoperative strength, and that they've regained all the strength they've lost from the initial SDR surgery. They've usually regained by about 6 to 8 weeks after the surgery. So how do I do it? This is an example of the size of incision you'd have for a multi-level approach with multiple laminectomies, laminoplasties performed over the whole of the lumbar spine. This has been associated in some series with greater risks of kyphosis, scoliosis, spinal deformity, of also needing prolonged periods of bed rest afterwards. And this is the advantage of a single level technique of lower risk of spinal deformity, lower amounts of pain potentially, and And also a shorter procedure, quicker procedure, because you've got less exposure during the surgery. And that photo at the bottom is some photo someone took of me doing my first one. So during the surgery, I don't know if this, yeah, last time I tried doing this video, it didn't work as well. So I use ultrasound. I use ultrasound to locate the level of the conus transcutaneously prior to the surgery. And this is a sagittal view ultrasound showing the tip of the conus with the dorsal sensory roots and the ventral motor roots. And then the technique is summarized here on the side. You can see the dorsal sensory roots here with the conus visible in the middle. If we look round at the side, we see that same pattern repeated of the dorsal sensory roots, then some conus, then the ventral roots. And I dissect the dorsal sensory roots towards me, place a patty in there. I then go to the very tip of the conus, identify the sacral nerve roots. The S5 is really thin and weedy, and then I develop back from there, S4, S3, S2, separate between S2 and S1, and then pass this green sling. So the green is basically because it's a radio opaque material. I'm not allowed to use a material that is not radio opaque because if it were to get lost during surgery, it has to be findable with X-ray. That's what my hospital insists on. And then I've got all of my sensory roots in that green sling. I then irritate those nerve roots, just gently agitate them with my probe. And with free run EMG, I should see silence from the sensory nerve roots, and then go around the corner and irritate the motor nerve roots. If something is unplugged, I'll also see silence from the motor nerve roots. So I want to see silence, then I want to see activity, and then I can get on with the rhizotomy itself. And that is summarized now in this short bit of video clip. So gentle initial irritation of those nerve roots. And I'm doing this to make sure that I don't have a motor root inadvertently within that bundle. And then going around the corner, checking the motor roots and checking the response of those motor roots. Now I get my probes in. These may look familiar. They are ball-ended blunt hooks like you would use as a nerve root, as a nerve probe to, for example, doing a discectomy. These have been specially modified. Pick up a portion of the nerve from one of the nerve roots, test it, get a response, and you've already had a talk telling you about the grading of those responses, so I'm not going to repeat that. So we get one response, neurophysiology have graded that, and then we do the second response. And whichever is more active between these two is the one that gets cut. And in this case, the second one was more active, and I've cauterized the little vessel that's running along it, and then I cut it. And as you can see, that's not coming back together. I need to make sure that decision is made carefully. So for every nerve root that I test, I divide each nerve root into three. I test one, test two, whichever is more active gets cut. I test three, whichever is more active gets cut. So I'm left with 1 out of 3. And I'm always, that's what I'm doing at every level, L1, 2, 3, 4, 5, and S1 on both sides. And a bit like with that question that was asked earlier, what happens if they're all grade 0s? Then yes, we check, have they accidentally had paralysis? Is there some problem with the testing? And otherwise, yes, if they are all identical responses, then I make that choice as to what gets cut. So they go back to HDU or the ward with an epidural, and then they have the physio like I've described. We have to think about they will still need some orthopedic input. They still need regular input from physiotherapy. They may need casting. They still need the range of movement monitoring. We've got physio recommendations from NHS England that we give them. I've currently treated 169 patients, roughly even split between GMFCS 2 and 3, more boys than girls. We followed up patients now. We've got 14 or 15 that we followed up at 10 years. As you can see, more heavily weighted to the shorter term follow-up, but a decent cohort that have come through at 5 years. We're seeing that spasticity is reduced for all patients. About 90% of our patients have got Ashworth grade 0 in their muscle groups postoperatively. About 10% have got a small amount of residual spasticity, but it's much better than it was before surgery. We published on our quality of life a few years ago, looking at the changes over the first couple of years, showing statistically significant differences. And this is what we're seeing at 5 years, that we're seeing pain and impact of disability is improving and staying improved. Participation, physical health is also improving, staying improved as we go along to 5 years as well. So we're seeing improvements in physical function, but also in quality of life. And certainly one of the messages coming through in the longer term follow-up are that families and the individual kids are talking to us about quality of life improvements more than they are necessarily about mobility improvements. And there's some of these other things like ease of orthotic fitting and less support when walking and things that are little things that are hard to measure that parents report make a big difference to life. One little video, a couple of videos of a young girl that I operated on a few years back. This is showing her walking before surgery. So she's up on tiptoes. You can see the crossing in of the feet, tendency potentially to trip over. And then this is her at 1 year. She is walking slower, but she is getting and keeping better flat foot contact. She is still weak, she is still strengthening. This is her at 2 years. So she's now not using a walking aid. Yes, her walking gait pattern is not perfect, but it's a huge amount better than it was before, as you can see. And she's walking without an aid. She does still have splints, but this is showing her without the splints. And this, she can jump. This was one of the things she couldn't do before surgery. And as you can see from that, very excited little girl. And that was what happened with her GMFM. So under natural history, she should have carried on down here. She's crossed from being a GMSCS 3 to becoming a GMSCS level 2. And being able to offer that sort of chance of improvement for even a small selection of patients is a fantastic thing for us to be able to do. So we're seeing improvements. We saw for her gait improvements, functional improvements, significant improvement in her spasticity. What do we know about SDR? Careful selection, goal setting is essential. Realistic goals are important. Making sure that we're clear with families, how much can they actually improve? What can they expect to see? And working closely with colleagues with physiotherapy, with orthopedic surgery. SDR does not replace the need for orthopedic surgery. It's not a competition for orthopedic surgery. It is a treatment alongside the orthopedic surgeons. So it's something that we're seeing good improvements. We're seeing maintained improvements for our patients. And I hope that's a useful overview.
Thank you so much.
Mm-hmm.
We have plenty more questions, I've noticed. I will start with you, John, if that's fine. One question is about patient selection criteria. What about patients who also have dystonia? Would it be recommended to perform SDR in patients who also have dystonia?
So there is a slight depends answer to that. The issue is partly how bad is that dystonia? Spasticity, because it's a resistance to movement, can rein in that dystonia and make the dystonia less pronounced. So if the dystonia is very mild, you might get away with it and it might be all right. If the dystonia is quite bad and quite obvious, you are likely to make it worse. There are some surgeons that will perform a partial ventral rhizotomy, motor rhizotomy, at the same time as dorsal sensory rhizotomy to try and combat some of that dystonia. How long lasting that is still, the jury is out. There is still research going on that. It's something that I do not do. It's something that I don't advocate because I've got no experience of it. And it's certainly risky to start cutting portions of motor nerves. So if there is a bit of mild dystonia, you may get away with it. You may be okay to do it. If you've got frank, really bad dystonia, then no, I would not recommend SDR in that setting.
Thank you. And the next question is on hemiparetic CP, predominantly in the lower limbs. If you would treat them and you would find abnormal responses during the surgery, would you also cut fascicles on or rootlets on the other side?
So coming back a little bit from that, when people have done studies looking at, and even when we do the grading of a non-hemiparetic, we get some crossover. So I can stimulate a right-sided nerve and get some left-sided response. So we know that that happens. And we know that from pathology studies, we can see little interneuron rootlets going outside of the spinal canal, linking one rootlet level to another rootlet level below. So we know there are various degrees of crossover. So there is certainly potential with a hemiparetic patient for there to be crossover from one side to the other. I personally haven't done SDR for any hemiplegic children. It is described, and it is described doing it, both techniques of doing unilateral only and bilateral as well have both been described. So from my own experience, I can't answer that, but both have been described and both fit with my experience and the published experience of standard diplegic patients having bilateral responses when you stimulate one side.
And then
I don't know if anyone else wants to speak to that question as well.
Tom, there are several questions to Andrew, so I think we may answer them. So how do you identify the sacral group of roots during SDR? This is for Andrew, I think.
Identify dorsal root?
The sacral group of roots during selective dorsal rhizotomy. How do you identify the sacral group of roots?
I have talked about it during intratensional AMG. We divide the root to the several rootlets for 4 or 5 parts, and then perform intraoperational AMG. And if we find a high amplitude motor response, or spreading this response to the several group of muscles, or find the response on contralateral side, this rootlets was cut.
Okay, thank you. Yeah, maybe also Simona, do you want to comment on the sphincter and anal sphincter and urinary sphincter function, how you could assess this, or what steps you would undertake as a IRM physiologist?
We observe the sphincter activity in the free running EMG and also during the stimulation. And at the end, in Berlin, we include also S2 sometimes, and we use this method from Deletis and measure the pudendal dorsal root action potentials. You stimulate the pudendal nerve and get an answer from the root from S2 and S1, and you decide if you have a high potential, then the surgeon will consider to cut a little part of S2 also. So some things to monitor also S2 functions.
Okay, thank you. Andre, there's another question. Do you always do baclofen trials? Is it necessary?
Yes, we have a high experience on ITD. And
do you always do a trial before implanting the pump, or do you sometimes immediately?
Yes, we perform a baclofen trial before pump implantation, and start dose was 20-25 micrograms. Then if we don't see a clinical effect, on next day we use 15 micrograms of baclofen, and maximal baclofen dose was 100 microgram. If
And
no,
then-
yes.
Yes,
Mhm.
sorry. And another question is about respiratory depression. If you see it in patients where the catheter placed in the cervical region,
Mhm.
so is there any problem with respiratory function?
No any problem with respiratory function. No.
Okay, thank you.
Mhm.
One more question about these surgical complications. Yeah, the most common complications, which is quite straightforward in my opinion. Yeah, one question about anesthesia for any of you. There are different recommendations in favor of gas anesthetics and in favor of propofol. Can anybody comment on this, on the anesthesia?
During general anesthesia, we use propofol, but we don't use miralaxant. Propofol don't pretend MG registration.
Anybody?
We're generally using TIVA as well. Total intravenous rather than using inhalational agents.
Mhm.
Thank you. Yeah, then one more comment from a Mexican colleague who mentions that about 10 years ago, he was used to perform about 10 SDRs per year. And since then, he only has performed about 5 in 10 years. Is this something you see in different centers, or do you have similar experiences due to maybe the overuse of botulinum toxin? Anybody wants to comment on this? We haven't had this impression. Not sure about other centers who have seen a decline in SDR.
The reason we've had a decline is COVID related, that community pediatricians aren't seeing as many patients face-to-face, community physios aren't seeing as many patients face-to-face. So if they're not getting hands on the patients, they're not appreciating how much spasticity there is. That's why we've had a difference over the last few years, but otherwise I wouldn't say there is a difference. If a child can be adequately treated with Botox instead of SDR, then in my opinion, they should be having Botox, not SDR, because it's reversible, it's less dangerous. So from that point of view, we actively encourage the less invasive treatments if they work.
Mhm. Is it possible to do selective dorsal rhizotomy for children from the group 4-5? I think it is possible,
Yeah.
but what will be the result?
This issue will be tackled by the last speaker, I assume. So,
Oh, yeah.
Yeah, we can go to the next speaker and then we can discuss the final question. So, yeah, on the last topic, the jury is still out, and this is the perfect question, I guess. Can we do SDR in patients with a 4 or 5?
Yeah.
And this is Philippe de Vlo, who is both a pediatric and a functional neurosurgeon, who will discuss this topic.
Thanks, Tom.
Yeah, Philippe, you are welcome.
Is everything all right from a technical point of view? Can you see my slides? Can you hear me?
Yeah, excellent.
Okay, great. So thanks, Tom. I'll talk about ITB or SDR for non-ambulatory CP. And I think everybody knows the schedule of GFMCS levels 1 to 5. So I think that in many Western European countries, this is sort of the treatment schedule for neurosurgical treatments. So some of the level 1s are too good to undergo anything at all, any neurosurgery at all. And then there's a group of 2s and 3s, which can be good candidates for SDR, dependent on the strength, on the appearance of dystonia, on the cognitive level, on the selectivity. If they are not good candidates, then we go for ITB. And then classically in grade 4 and 5s, most people tend to go for ITB. However, this is an ongoing debate, and there have been some interesting publications over the last few years. And so is it an option to go for SDR instead of ITB in these non-ambulatory patients? And I think one of the most important people in that field was Michael Vloebers. He's a neurosurgeon from Nottingham in the UK. And so this is an article he published in 2015, 2016, where he used SDR as an alternative to intrathecal baclofen pump replacements in these patients. And so I spoke to him a few times, and he was actually struggling with a few patients who had lots of complications. And it was his idea to start with SDR in these patients who previously had ITB. And so it was a small series he published, I think about 10 patients. You can see that they were all GFMCS 4 and 5s. And then he noted that not only in the lower limbs, but also in the upper limbs, and there was an improvement in modified Ashworth scale. And so you can see there's an improvement of 4 grades sometimes, and so dramatic improvements in modified Ashworth scale. And not only in the lower limbs, but also in the upper limbs. And so that was already touched upon before, but the upper limbs seem to benefit as well from SDR. More importantly, he also noted that in a few patients, there was an improvement in neurology as well. And so generally, there is no improvement in neurology with ITB. However, in a couple of patients, he saw that after SDR surgery, their continence tended to improve. So those are about 3 out of 10 patients. So those are interesting findings. And if he asked the parents, then most parents said it was actually better with SDR as compared to ITB. Obviously, that's very subjective. Only one patient said it was equivalent to ITB. So then he carried on, and then he decided to start off with SDR, not as a rescue treatment for people with ITB complications, but also as a primary treatment in this group of grade 4 and 5 GFMCS children. And so this is a larger publication from 2018, where he compared the lower limb Ashworth score in 4s and 5s, and this is the reduction after SDR surgery. So you can get about a 3-point reduction in modified Ashworth scale in spasticity in this patient group. So very similar, I'd say, to the GFMCS 2 and 3 patients that are the classical candidates for SDR. And again, he was able to show that that's not only the case in the lower limb, but also in the upper limbs. And so the upper limb reduction in modified Ashworth scale was very similar to the lower limb reduction. Again, what he noted in the previous series is that there seems to be an effect on continence as well. And so this is a table showing the continence pre-op versus post-op. And what you can see is that children who were pre-op dry were in 100% of cases also post-op dry. So it doesn't seem to be risky to damage the continence, as we know from the 2s and 3s, but also in the 4s and 5s, it seems to be relatively safe as from a urinary viewpoint. Interestingly enough, he saw that there was a fairly large group of about half of patients who were pre-op wet who became post-op dry. And so that's an interesting finding as well that I haven't seen myself with ITB. So this is the largest series from Nottingham. About around the same time as in Nottingham, there was the group from Amsterdam who also decided to try SDR in these non-ambulatory children with severe spasticity. And so these are a few conclusions from their paper on that. And so you can see that there were improvements in various fields, and I will show a figure on this in a few seconds. But that the grade of satisfaction was also very high, and so parents reported about a 7 on a 10 scale satisfaction rate. And SDR resulted in reduction in spasticity, but they saw in this group that a fairly high number, 9 patients, showed dystonia after SDR. And those were especially children with congenital malformations and syndromes. And so it seems to be working well for spasticity, and there is an improvement in various fields. The satisfaction is high, but it's risky to induce or to reveal dystonia. And so this is the graph from their study showing the different domains, where you can see that especially in dressing and washing, and there is an improvement after SDR surgery. And so that's the aim of SDR surgery in this group, and we don't do it to allow them to walk, and these children will remain non-ambulatory, of course, but you improve nursing, and you improve the ease of care and the comfort, and that's why we do it. And so you can see that dressing, washing, and comfort seem to improve after SDR surgery. However, they noted that a relatively high number developed dystonia, or dystonia may have been present before, but it was revealed after SDR surgery. So then they published another paper to look for risk factors and to induce dystonia. And so what they saw as the only predictive factor is that children with congenital or genetic disorders had a much higher risk of dystonia. And so it doesn't seem to be a good idea if there is any sign of dystonia or any basal ganglia lesion or any sign of progressive disease, and to do SDR in these children. I've only shown a few papers from Nottingham and from Amsterdam, but there have been some reports on this subject, and these were nicely summarized in a systematic review from Toronto, where they were able to say that it seems that from the literature, both ITB and SDR can lower spasticity and improve gross motor function in these non-ambulatory children with CP. Obviously, complication rates were higher after ITB. That's not very difficult to imagine. And because there's an ongoing risk with ITB, whereas with SDR, it's a single intervention and there is no risk afterwards anymore. However, there's a lack of comparative studies, and the outcome measures may not be very relevant to this population as well. And so most studies are focusing on spasticity, but very few studies are focusing on outcomes such as care and comfort. So to say a few words about complication rates, I'm sure that many people think that ITB complication rates have gone down with the new Ascenda catheter, for instance. But if you look into the real world data, this is from the product surveillance registry of Medtronic. This is with the latest version of the Ascenda catheter. You can see that in the x-axis, the time in months, and in the y-axis, the survival rate of the catheter, and that the survival rate of the catheter has dropped to about 80% after 5 years. And so within the first 5 years, even if you use an Ascenda catheter, you will have to replace about 20% of these catheters. And that survival rate goes even further down around the time of the first pump replacement. So yes, there's a much higher complication rate with ITB, and there's an infection rate. You all know these risks. And so in general, you can say from the literature that the reintervention rate is about 6 to 10% a year in the first 6 years. So that's before the estimated battery survival of the pump. And so there's a fairly high ongoing complication rate with ITB. Whereas with SDR, although there are a large number of possible complications, the actual complication rate seems to be very small, and it's probably less than 5% overall. So if they are as efficient and if the complication rate is lower with SDR, what could also contribute in this discussion is the cost. So I'm not sure if you realize how much ITB costs, but it's a fairly expensive treatment. And so the cost for the first year has been calculated in our country, in Belgium. And you can see that if you take into account everything, including the infection rate, including the catheter blockage rate, including the refills, and that for the first year, it's about 40,000 euros if you go for ITB, whereas if you go for SDR, it's about 3 times less. And this is an ongoing issue because these people with ITB will need pump replacements, but also refills over time. This is not only the case in Belgium, but there are some older studies from the UK and from Canada that maybe in absolute numbers are no longer correct because of indexation, but in relative difference are very much similar to what we found. So 3 to 4-fold difference between the two treatments. And as I said, this is an ongoing issue. If you calculate the expected costs per year and you multiply that by the life expectancy for a 10-year-old with non-ambulatory CP, which is about 33 years, and then you will come above the 100,000 euro threshold. And so this is a very expensive treatment over time. So that's the reason why we decided to set up a study in collaboration with the Dutch groups and the groups of Amsterdam and Maastricht and a few groups in Belgium. So we collaborate on a study where we want to include 48 patients with spastic CP, grade 4 and 5. We exclude dystonia, we exclude basal ganglia lesions, and we exclude progressive or genetic diseases. We will randomize between SDR and ITB, and the primary outcome will be a quality of life scale specifically designed for CP children, which are non-ambulatory. And there are some secondary outcomes which are also important, the complication rates and the costs. And so the core study will be only 1 year post-op, but will have a long-term extensions until after the first pump replacement, and will hopefully start early next year. So for now, I can recommend until the RCT has been conducted and published that SDR may be an alternative to ITB for spasticity reduction in GFMCS 4 and 5 CP. However, I would definitely restrict it only to pure spastic CP. And you need to realize and explain the parents that the treatment goal in SDR is completely different from the ambulatory children. And so we're talking here purely about comfort and nursing. In UZ Leuven, we offer it as a primary treatment if there are absolutely no dystonic features nor basal ganglia lesions, and if there is no evidence for progressive disease, and if the patient understands that the knowledge on SDR for this indication is limited if you compare it to the knowledge about ITB. And we also offer it as a secondary choice in children who had ITB previously and who suffer many complications. That's all I wanted to say.
Oh, thank you so much, Philip. So you see, now we learned two reports where there was a comparison between the two methods of treatment. So Andrei, have you have the same opinion concerning the comparison of these methods?
Yes, of course. SDR is quite effective in both group of patients with CP. And the results of ITB in follow-up, I have shown that the spasticity tends to increase since 2-3 years after pump implantation, because it's preferable to perform SDR, both in CP patient prospective for motor rehabilitation and without prospective.
Okay, thank you. Tom, I think that we may spend 10 minutes to answer the majority of questions. So would you announce the questions?
There's few questions on SDR for upper limb spasticity. Is there anybody who wants to comment on this?
Mm-hmm.
If it's feasible, if it has been done, if you have done it. Somebody?
I've heard of it being done, but then you've also got to compare it with other methods of spasticity treatment, such as focal Botox and peripheral neurectomy, which are the plastic surgery techniques. So it's also a very different thing, because where you can do SDR for all of the lumbar nerve roots at the conus, to do it for cervical, you've got to open up a large portion of the cervical spine to get there, and you're going to have multi-level laminotomies or foraminotomies to get to those nerve roots. So it's going to be a much more involved procedure, and most of the time, if you're talking about upper limb involvement, you're talking about upper limb as well as lower limb anyway as well. So I've heard of it being done, but we've not done that. Generally, we've used SDR for lower limb spasticity, and if there is a persistent upper limb problem that needs addressing, we usually refer to the plastic surgeons.
Okay, thank you. So one question for Philip: have you had patients where after SDR you performed ITB? If so, have you had problems with catheter placements?
So yes, we had a very small number of patients who had ITB after SDR, and it's actually not a problem at all. I don't see a big deal. Theoretically, there could be some arachnoiditis, but you see the same in spinal cord injury. So I'd say maybe there's a higher risk of catheter blockage, but it's probably not higher than in spinal cord injury patients. The opposite counts as well. So you can do SDR after ITB. What you see in general is that the roots are more scarred, and that there is also some arachnoiditis, but it's actually not a problem from a technical point of view. You can still do SDR. So both are possible after one another, I'd say.
Just one question from my side now. Is there anybody who has experience with the redo SDRs, or like John, maybe Andrei?
I personally,
if the first
I
SDR wouldn't be sufficient, I could imagine that, or you haven't had any cases where this was insufficient. Or...
I say to my patients that I wouldn't go back in, because I can no longer because the roots end up clumped. I can't differentiate, not at the conus level anyway. I can't differentiate what is what. And if I've cut 2/3 already, I don't want to take them over that 75% boundary. I don't want to risk the proprioception. So for my patients, I say there is no option to repeat.
And another question for you is, how do you identify the conus or with the single level laminotomy? And then the second question was also related to this one is how would you compare the results of single level laminotomy versus the multi-level procedure?
Well, identify the conus itself, I do with ultrasound percutaneously prior to starting. And actually, once you've done it a number of times, you're used to where to expect to find the conus, because when the child is prone, you can feel on the rib cage, and actually that takes you to the top of the L1, to the level above the spinous process of L1. You're going to be either side of there. That's what I generally find. But I use the ultrasound percutaneously as my level check to confirm the level for the conus itself. And then comparing single level versus multi-level is really a case of, if you cut 2/3 of the nerve roots through a single level approach versus multi-level approach, you're still effectively doing the same operation. It's just then down to things like post-operative pain, whether there's a difference in risk of spinal deformity in the future. But looking at the standard measures like modified Ashworth score, the GMFM, the measures of timed up and go, looking at gait analysis, those apply whatever technique you've used. And there's no reason why you can't do some meta-analysis looking at those different techniques at different centers and combine them all. My preference for a single level, our preference for a single level in Leeds is because it's a defined technique, it's a smaller incision, it's a quick recovery, and it works well, so that we don't have a need to change it and go for a longer incision.
Somebody else wants to comment on this? Okay. Then there is a question about basal ganglia lesions. So you mentioned that these patients have these nice periventricular lesions and you would rule out different lesions in other structures. But what if you encounter a patient who has a pure spastic CP, but has lesions on the MRI scan in the basal ganglia? Would you still consider SVR?
In our center, no, we wouldn't, because that is, as far as we're concerned, that is a clear indicator of risk of dystonia. So, and if we haven't appreciated it before surgery, certainly expect it to be unmasked by the surgery. And for us, it's a contraindication.
Okay, thank you. Yeah, question for Philip. Besides spastic CP cases, when is SDR recommended? Apart from CP, spastic CP cases, is there other indications?
I'd say, as far as I know, SDR, but that's the only sort of accepted and established indication for SDR. There are some experimental indications. I saw that there's a question on stroke as well, spinal cord injury, but that's not established. So I'd say, to me, the only established indication is spastic CP.
Totally agree.
Then there's a
the problem is it's an irreversible procedure. So we are moving into the territory of experimenting on people's children or experimenting on human lives with an irreversible procedure if we start doing it in other things. And that's where we've got to be really careful. There is a line that we've got to make sure we don't overstep. Yes, we've got to advance treatment, we've got to advance care, but we've also got to bear that in mind as to how much we are genuinely expecting to help them versus just giving it a go.
Okay, yeah, there's one question for Andre, but I think he left. Maybe somebody else wants to comment on this, but it's during neurotomy, if the fascicles give different CMAP because of different amount of motor fibers, how do you decide the 50% to cut? Anybody who wants to comment on this?
So yeah, we've done a few tibial neurotomies, and there we simply cut a certain percentage, a predefined percentage. So for instance, 80% of the roots that go to the soleus muscle. I'm not sure if it was mentioned in this talk, but I would also advise not to simply cut the nerve, but actually to excise a centimeter or so of the nerve, just to make 100% sure that there is no reanastomosis of the nerve afterwards. But yeah, we would just cut a certain percentage without really relying on the CMAP. Except for the branches that serve the skin, obviously. But if you have defined a fascicle that goes to the muscle, then we would just cut 80% of the fascicle. So.
And then one more question for Dr. Walter. There are cases, for example, by stimulating the second lumbar nerve on the left, we could also get responses from the right second lumbar nerve. What do you do in this case? And can this be regarded as a grade 4?
I didn't catch the beginning, and you have to they have to say, is it with low frequency stimulation that they have contralateral responses, or is it with
yeah, it's not mentioned, but I would assume it's of high frequency 50 Hertz stimulation, as you discussed.
Yes, with a high. And what level was it?
It was an L2 left side, I assume. I just
if it is in connection with a 50 Hertz response, I would say it is grade 4.
Okay, thank you.
If you have a contralateral.
Yeah, there's a few questions, but I think we already tackled these about sphincter responses. How do you determine these? But you just already answered that question. And then there's another question on, sorry, just go ahead, please.
If you talk about sphincter response, we didn't count or we did not grade the sphincter responses because you can also have sphincter responses a long time before you came close to S1 and S2. So Dr. Park's team will not grade with sphincter responses. And so we have done it also not.
Okay, Tom, our participants are very active, but the time of our webinar comes to the end. So unfortunately, I think that we cannot answer all the questions online, but I want to remind that Zoom permits to answer the questions offline. So all the speakers, I think, should answer the questions related to their experience for our participants as well. I think that our webinar is recorded, so our participants may look it through once more. Yes, Tom and Radek, we have come to the end. So, and I'd like to thank all the speakers. I hope that you have clarified many questions of this very complicated problem. So I want to thank all the participants for their very active interest to this problem. So, and I want to thank Tom for the chairing of this session and for the collaboration with the pediatric section, which appeared to be very effective. And I hope that we shall have another webinars where we can compare our results and to come to some decisions. So please, Tom, can you say some words in the for our participants?
Yeah, thanks again to all the speakers and everybody for your participation. It's always surprised me how many questions there are and how little time we have. So thanks a lot and hope to see you soon. And we hope to have another joint seminar maybe on epilepsy surgery soon. Thank you all.
Yeah.
In 2 months. In 2 months.
Yeah, please, Radek. Yeah.
Yeah, we will meet again on 24th of April, and the topic will be epilepsy. So we will be announced soon, I guess.
Yeah. I think that it will be as well as successful because today we have about 200 participants, so it's very, very, very good result, and it reflects a great interest to this program. Thank you so much. Thank you so much. Have a good evening.
Have a good
Good
evening.
evening.
Yeah.
Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Bye-bye.